harala is atlin is altigurine lagen, hutangi hinudikiang, Roald Helgesen yat harakil hinudikiang. Good people, Háw'aa, Gunalchéesh, thank you for joining us for today's lunchtime chat with Tlingit Haida. My English name is Roald Helgesen, and I serve as the Chief Operating Officer with the Central Council of Tlingit Haida Indian Tribes of Alaska. Today, I am very pleased to have with us SEARHC's Chief Medical Officer and Senior Vice President, Dr. Elliot Bruhl. Dr. Bruhl is going to join us to provide you with a very special presentation on the coronavirus vaccine and also answer questions that you as citizens may have. His presentation will address the current status of the vaccine, how it works, its efficacy, and the side effects and safety of the coronavirus vaccine. So let's get started. Dr. Bruhl, thank you for joining us. Could you introduce yourself to our guest today?
Thank you, Roald. It's wonderful to be here. As you mentioned, I serve as a Chief Medical Officer for SEARHC. There's a bio there, which is quite detailed. But I've had the honor of working in Southeast Alaska, dating back to the mid-1990s. I also worked as a medical director at the Mayo Clinic for 5 years, which was a wonderful opportunity. And for the last 2 years, I've been back and serving as the Chief Medical Officer here at SEARHC. Gunalchéesh yuhat duasalk yechna ayahat luknahadi hatsati glekayadi ayahat shitka kwan ayahat. So my adopted Tlingit name is Gunalchéesh. I'm a member of the Coho clan and I live in Sitka. And it's an honor to be with you today and to be talking to you about the coronavirus vaccine. I did give a presentation on this probably about 6 weeks ago, I think, at one of these lunchtime meetings. And what I'm going to do today is I'm going to include some of that information for people who may not have seen that presentation, but I've really more of this presentation is an update. So it includes information that's new. I'm going to be talking a little bit about the issue of COVID-19 variants. I'm going to be talking some about the Johnson & Johnson vaccine, which of course we didn't talk about last time. And so there's some new information in here, and let's see if we can get that rolling. So I'm just going to tell you that I'm getting a message here about the fact that I'm not quite able to share my screen. Let's give it another try. There we go. All right, and let's see if we can get that rolling. Looks like that's what I was hoping for. Are you able to see the presentation there, Roald?
We are, Dr. Bruhl. Okay, if you're ready, please feel free.
Yeah, I am ready. So, so what we're going to be talking about today, in order, we're going to talk about what are the purposes of vaccines, how do they work, how do these vaccines work, specifically the mechanisms of action, the data on their effectiveness, the documented side effects, safety, and then this is a fun conversation, is the development and how did this happen so quickly. I will give an update on SEARHC's vaccination numbers throughout Southeast Alaska. That's not the complete numbers for the entire Southeast, but it gives you some idea of some of the dimensions of what we've been doing. And then we're going to talk also about COVID-19 variants and the vaccines. Lots of great questions there. I would encourage you to please use the chat function on the Zoom meeting to write down your questions. And what I'm going to do is I'm going to move through this presentation in a steady fashion. And then when we get to the end, we will begin addressing your questions. So please type them into the chat whenever it becomes something that a question that you have. So difference between vaccines and drugs reflects the really a difference in approach. So we have a number of medications that have been approved for treatment of COVID-19. Hydroxychloroquine was briefly approved. That approval's been removed. There's some other medicines that are new that are being used. There's an unapproved medicine, dexamethasone, that's been very effective, but is an existing medicine. Vaccines, of course, are designed to prevent illness in people who are well, so that it could kind of have a different, it's a different approach to healthcare, and one of the most profound approaches that exists, because as we know, vaccines over the course of the last 300 years have really changed the health status of human beings on the globe. So the coronavirus is a respiratory virus, which means that it's spread by in respiratory droplets from one person to another. This is a color enhanced picture of an actual COVID-19 virus taken with an electron microscope. And what you can see on the surface, these blue, little blue ice cream cones here sticking out of it, that is what's called the spike protein, or the S protein. And that protein is the really the doorknob that opens the way into the body for the virus. So this S protein allows the virus to move into the cells of a person who's sick with it. So it's really all of the attention in understanding the behavior of the virus is focused on that. So we have basically two flavors of vaccines. One of them is called a messenger RNA vaccine, and the other is called a DNA vaccine. So the messenger RNA vaccine is the one that we're all familiar with, and the one that we've been distributing in Southeast Alaska primarily. And that includes both the Pfizer and the Moderna forms of that. For all intents and purposes, when these vaccines actually function, they're identical. So the messenger RNA is a set of instructions that is in the vaccine, that is injected into the person that is receiving it, and this acts like it acts like a school teacher within the cells of this person, and teaches those cells to produce little fragments of protein. So this exact same protein that exists on the surface of the virus, that you remember, the blue things here, those are then being produced in the body of the vaccine recipient. And then what happens is that the immune system of that person learns to recognize those and to attack those. And so then when the actual virus shows up, the body is ready to attack the virus because it has antibodies directed at those spike proteins. So that's really how the messenger RNA vaccine works. Now we give people a second dose, because the second time that this comes in and those spike proteins are produced, then the immune system really gets revved up and really produces a large number of antibodies, and it improves the safety of the coverage for that person. So now that person is immune to the virus. So this slide talks about the Johnson & Johnson vaccine, which is a DNA-based vaccine. And here you can see on the right side what I was just talking about. So the vaccine goes in, there's the messenger RNA, and it's inside the host cell. This is a cell of the body of the person who just got vaccinated. And the manufacturing aspects of that cell now are taking that messenger RNA from the Pfizer or Moderna vaccine and producing these spike proteins, as I was just describing. And then those are going out into the body and promoting an immune response. Now over here on the left side, you'll see another needle injection, and this is the Johnson & Johnson. And the Johnson & Johnson vaccine is a DNA vaccine. And here, this little red piece of DNA in this upper left side is inside of a weakened cold virus. So it's a cold virus that's inactivated. It won't make you sick, but that is the delivery package. And so a little bit of that spike protein, the DNA that codes, or the instructions that code for that spike protein are inside of that weakened virus, and it comes into the host cell, and then the DNA from that vaccine-based viral package now goes into the host cell nucleus, which produces messenger RNA, and the messenger RNA comes back out here. And now we're just back where we started from with the messenger RNA and with the messenger RNA vaccine, and everything then proceeds the same way. So it's just a different mechanism of getting to the same spot. Now, one of the things that's very important for people who receive the vaccine is that this only requires a single shot. And as I mentioned earlier, the messenger RNA vaccines require 2 shots. This is a graph that shows the effectiveness of the messenger RNA vaccines, and I showed this in the last presentation I did. And this is from the stage 3 trials. So this is from before the vaccine was released, when its safety and effectiveness was being proven. So this is a graph, and what happened in the stage 3 trials was that there were 2 groups. One group got the vaccine and one group got salt water. So that's called a placebo, or it's a sham, or it's basically the control group to see what happens if somebody gets a shot but it doesn't actually have the vaccine. So for the people who didn't receive the vaccine, you can see these little red dots. And what's happening is that as time marches out to the right, which is here you see on the bottom the number of days after they received the dose, and going up vertically is people catching coronavirus. And you can see for the people who got the placebo or the sham, as time marches out, more and more people are just getting the virus. And that means that the salt water that they were given didn't protect them. Now the blue line down here below, those are the people who actually received the Pfizer vaccine. And as you can see, as time marches out, it's just flat. People in that group are not getting the coronavirus. The effectiveness that was demonstrated in these phase 3 trials that were done with many thousands of people showed that it was 95% effective, which is really extraordinary. We really don't have very many vaccines that are even close to that effective. So this is an extremely effective vaccine. For example, many of the times when we give flu vaccines, they're only 30 to 40% effective for an individual, but still worthwhile because it shuts down the epidemic. Now here's Johnson & Johnson. This is the exact same kind of graph, and it's from the phase 3 trial. And you can see again that people who got the placebo or the sham, they continue to contract the coronavirus, and the people who received the shot, this is a much flatter curve. Now it's not as flat as the It's not as flat as the Pfizer. So what does that mean? Well, as it turns out, what that means is that the Johnson & Johnson vaccine is about 70% effective. So it's not quite as effective as the Pfizer, but it's still very, very good. And as I mentioned to you earlier, in the world of vaccine, this is an extremely effective approach. But I think the other thing, and this is important for our later conversation, it's not like throwing a light switch. It's not on and off. When you're vaccinated and it's 70% effective, there's still you still have some significant risk, and some people who are vaccinated still are going to contract coronavirus. Now, one of the great things, though, about these vaccines is the people who do contract coronavirus don't appear to be getting very sick at all. So they're not landing in the hospital, they're not landing in the ICU, they're not landing on life support, they're not dying. So we're doing ongoing surveillance of people who've received the vaccines. And here we're not talking about a couple hundred, we're talking about many millions of people, hundreds of millions of people at this point around the globe. And this is what the data is showing. Side effects for all three vaccines are the same. You can count on the fact you're going to have a sore arm. How sore is a sore arm? I don't know. I'd say it hurt about like when I was a kid and my cousin punched me in the arm and it hurt for about a day. So it's not too bad, but not something that any of us would want. Headache and fever in the trials were shown to be occurring in only about 5% or 5 out of 100 people who received it. Reality is, in practice, it might be a little bit higher than that. Fatigue is common, and also muscle pain and joint aches. Some people experience sort of a flu-like syndrome. None of this is long-term. Almost always it resolves within a day or so. Did you have any of these symptoms, Roald?
Yeah, I did. I had fatigue, a bit of a headache. The second shot was worse than the first, but it's way better than COVID.
Oh yeah, absolutely. Yeah, one of my daughters had COVID, and months later she still can't taste her food. Thank God she didn't get any sicker than that. Severe allergic reactions, or anaphylaxis. Of course, this is something that you see a lot of in the press. It's not something that is common. And at this point, after giving millions of doses of this, we know the frequency of this is more on the order of 8 in a million. We did have one of these occur in Juneau on the very first day that vaccine was being offered. And of course, that's the way, Murphy's Law works, and that's the way things are. One thing I like to remind people of is that in medicine, we are familiar with this phenomenon. We do see it, not just with vaccine, but we see it when we give people all types of medication, including basic blood pressure medicines or injected antibiotics, et cetera, et cetera. So that is something that we're used to, and we have the medications available wherever we give these vaccines, so that God forbid if this were to happen to somebody, we're ready to treat it, and so those medicines are available. Again, a very uncommon thing, could happen in really with any medication we give. So with regards to safety, I've explained the mechanisms, and I think one of the things to realize is that these vaccines do not include the whole COVID-19 virus. These are not live virus vaccines. They're not dead virus vaccines. They do not include the virus. So it's a physical impossibility for somebody to contract the coronavirus from receiving the vaccine. The other question that I get about long-term safety is because these vaccines include genetic material, is that somehow something that's going to alter my genetics. And so what I would like for you to understand about viruses and about genetics is that you are familiar, your body is familiar with the phenomenon of genetic material from the outside. So every single time in your life that you have had a cold or you've had the flu, what that has represented is foreign DNA or RNA coming into your body in the form of a virus, and your cells will process that, your immune system will destroy it, and there's no residual effect on the genetics of your cells. The material that are in these vaccines do contain the instructions that are necessary for your immune response, but your body processes the actual content of the vaccine, and it is destroyed and recycled very, very promptly within a matter of a day or two. So messenger RNA exists in every single cell in your body, and those cells are constantly processing it and reprocessing it. So there's nothing about this that's a long-term residual. Now, this isn't speculation. This is actually the science that we are completely aware of for many decades, and it's the same science that's made it possible for us to develop these vaccines and many other medications that we use in caring for you. People ask, how is it possible that in 8 to 10 months that these vaccines could be prepared? Certainly they had to skip steps if they did it so quickly. There had to be shortcuts. The amazing thing is that that's not true. The really amazing thing is that all the steps that we have come to expect in the development of a vaccine have been utilized, and there's been a very, very robust process. There's a number of things that have made that possible, and one of the most important was that a lot of the work on this vaccine has been done for the last decade. So there was an outbreak of a similar type of virus about 7 years ago, and a tremendous effort went into producing a vaccine for that. That never turned into a pandemic, but much of the work that was done there has been translated into these vaccines. Another really important thing is that the state of our medical scientific ability continues to progress. And the ability to sequence the DNA of a virus and to design a viral or a vaccine response, and then to ramp that up into production, that didn't exist 5 years ago. As a matter of fact, it didn't even exist 3 years ago. It's just simply a matter of progress. And there's many things that you are probably familiar with that have benefited from the same exact technology. So if many folks receive insulin that is called Humalog, which is basically it's human insulin. But where did we get that? We didn't get it from people, and we didn't get it from pigs like we used to get porcine insulin from pig pancreas. It's manufactured, and it's manufactured using the same technology that led to these. It's genetically identical to human insulin, and what a wonderful thing that we're able to do that. It's the same technology. I'm sure, sadly, many of us have family members who have cancer, or we have cancer ourselves. Many of the medications that we have now for cancer are directed directly at the cancer cells from a genetic point of view. And that, again, uses this same technology. And the days, we still sometimes have to use chemotherapy that makes people deathly ill. But many times we don't. Many times we have very directed therapy, you know, and breast cancer, while it still is a very, very serious disease and kills many people, for many people, it's become a very manageable cancer. And again, that's because of the technology that's gone into the medications and treatments. So these technologies are really part of the whole medical landscape. Vaccine development goes through many stages. All of these stages were utilized and respected in the development of these vaccines. And you can see the stage 3 trials include 43,000 folks from Pfizer, 30,000 from Moderna, 60,000 for the Johnson & Johnson vaccine. So robust trials. Now, some of the questions I've received in previous presentations about this to our beneficiaries, and it's an excellent question, is, well, were Native people included in these trials? Some, but not very many. And that wasn't really an oversight. What it reflects is it reflects the challenges around trust with healthcare after the many sad and difficult things that have gone on in Native healthcare in the last century, and in particular. So I know that Pfizer and Moderna actually went down to Four Corners and tried to enroll Native participants in the phase 3 trials. They had a few takers, but really not very many. Similarly, in other communities of color, both Hispanic and African American communities, there was not good participation. And that doesn't surprise me. You know, if you look at the racism that is experienced in all of these communities and in Native communities, it engenders distrust. But at this point going forward in the pandemic, we've had, you know, many hundreds of thousands of Native people who've received these vaccines and are benefiting from them. And we have good data to show that the recipients of these vaccines are doing well. So we're finding a way forward. These are vaccination numbers for some of our SEARHC communities. And from an epidemiological point of view, we want to vaccinate at least 70% of the population in communities. And you can see that we have, if you look at the population of people who are over age 16, who are the potential recipients, and you can see that we are at 50 to 70% of the population in the majority of our communities. And the words complete here on the end mean that we're over 70%. So I'll welcome your questions and comments about this. I can only tell you that this slide represents many, many thousands of hours of really hard work by our staff. A lot of blood, sweat, and tears. I'm really proud of what we've accomplished with this, and it does contribute to not only the safety of our communities, but also the potential economic health as well. This is a slide that shows a scientific scheme of the coronavirus and its genetic material. And so it's genetic material, it's an RNA virus, and you can see this is a schematic diagram of the genetics of the spike protein. It's got all of these different features on it. And when we talk about genetic variants or variant strains, what we're really talking about is the evolution of the virus. So millions and millions of copies of the virus are being created in a person who's sick with coronavirus. And when that happens, there can be random changes in the genetics, and some of those changes could lead to increased strength of the virus or increased ability of the virus to be shared from person to person. So recognizing this, here in Alaska, we're now basically every positive case of COVID-19 at this point, a sample is being sent for genetic analysis. So we're monitoring here in Alaska for those genetic variants. And a great example is the fact that the flu virus, we all know that, we have to have a new vaccine for the flu virus. And why the heck is that? Well, it's because of the fact that the flu virus evolves from year to year. And every year we have a new variant. And so this is not some new space age issue. It's something we're all very familiar with. And, the real question is about, what is the effectiveness of the vaccines? And current research does show that the existing vaccines are effective against the emerging COVID-19 variants. That doesn't mean that that's a situation that'll persist, but at the present time, fortunately, that is true. And when I say at the present time, I can tell you, I've been reading the medical journals from this last week. I read them every week, but there's articles that have been published just in the last week that are showing that this is the case. So this is actually a colorized electron micrograph of the spike protein, and you can see that when variations occur, they're very tiny, little tiny small regions, but that can have a big effect on the transmissibility or the danger that the virus poses. And these graphs on the right are data from trials looking at the effectiveness of antibodies against these variants. And you can see on the bottom axis here listings of these different variants. Here's B117. That's the variant that has come out of Europe and England. You can see here D614G. That is the variant that we've been fighting for many months in North America. And you can see here's the other two that represent the variants from South Africa. And actually, it does not, we don't have data yet on the variant from Brazil. But what you can see is that the amount of antibody that's effective against these variants, which is what is being measured here, is substantial and positive. So there are good data to show that our vaccines are effective. And then the epidemiological data also back that up. And what I mean by that is what we don't see a huge influx of people that are very sick or dying from COVID-19 from these variants. So the vaccines are holding true both, in the test tube and also in the field. So you can potentially spread COVID-19 after you're vaccinated, but what we know is that the vaccines, we now have data that show that the vaccines reduce the likelihood of that by something between 66 and 80%. So it makes it very unlikely, but nevertheless, you need to continue to be cautious, especially when you're in public, especially when you come into the clinic, especially when you're around somebody who's vulnerable. The CDC has been issuing new guidance for that. There's this concept of a breakthrough, which is that somebody contracts COVID-19 after they've been vaccinated. And one of the things that contributes to that is the timing of the first dose. So what often happens is that somebody's already contracted it and then they get their first dose of vaccine, and then 7 or 8 days later, they show up positive. I know it's popular for people to just get one dose and not get the second. If you just get one dose, the effectiveness is at 57% instead of 95%. So I want you to get the second dose. I want you to get the second dose because it's going to protect you from deathly illness, and it's also going to protect your community. True breakthrough of the vaccines. Okay, so I've told you that the Johnson & Johnson is 70% effective, the Pfizer and Moderna 95%. Well, that still means that there's some people who are going to get vaccinated and who are going to may still contract it. So if you vaccinate 100 people with Pfizer, there's going to be 5 of them who potentially will contract the virus. What does that? So that's not hopeless. That's not bad. As a matter of fact, it's outstanding. And the good news is that the 5 who get it, the data show that they're not going to end up in the hospital. So generally, these breakthroughs are asymptomatic. And as I mentioned earlier, it's actually 66 to 80% reduction of the likelihood of people getting an asymptomatic infection. So people are considered fully vaccinated 2 weeks after their second dose in the 2-dose series, or 2 weeks after a single dose for Johnson & Johnson. CDC has recently issued guidelines to say that if you are fully vaccinated, and I just gave you that definition, 2 weeks after your second dose, you should be able to get together in small groups indoors with other people who are also similarly vaccinated. And I did that last weekend with some friends I have really hadn't had a chance to see in many months. And I can tell you it was really good for my mental health. And I encourage you to get vaccinated and then enjoy the opportunity to socialize once again with members of your family. Also, if you're fully vaccinated, it's considered by the CDC and by myself that it would be safe for you to get together with some people who are unvaccinated, as long as we don't have somebody who is really vulnerable in the group. And lastly, if you've been around someone who has COVID-19 and you're fully vaccinated, you don't have to quarantine or go through a whole bunch of testing. So isn't that wonderful? So we're making progress. And there's some references, and Roald, we can arrange for this to be posted on your site, and we'll post it on the SEARHC COVID-19 website. And if people want to review those references, it's available for them. So let me go ahead and.
Well, Háw'aa, Dr. Bruhl, and before you answer questions from our people, I want to give thanks to you and SEARHC for partnering with us to ensure our tribal members our citizens are receiving accurate information on the COVID vaccine. There's so many different views and claims that are out there right now in the news and in social media. Misinformation risks undermining the public health efforts, and it's important that our tribal citizens have facts to base their decisions on. We hope that this presentation does relieve a lot of anxiety that folks have and that they make informed decisions. And we know that our SEARHC staff has worked tirelessly to vaccinate our friends and our family across the region as a partner, and also to treat those suffering from COVID-19. You are all, each and every one of you as staff at SEARHC, appreciated for your hard work and your dedication for our people. Háw'aa and Gunalchéesh for that.
Gunalchéesh, thank you. Thank you, Roald, for acknowledging all of our staff. It's a big group. We've got 1,300 plus people working for SEARHC, and this has been our number one priority in recent weeks. And I think it's been an honor for for those of us that are involved in it, but of course, it's also been a great strain. But it's part of, it's what goes along with providing healthcare. And, we don't really get to choose the problems that we have to face in our lives. And I don't think anybody who ever went into healthcare said, "Oh, I really want to get signed up for something I'm gonna get to work in a pandemic." But I'm proud of people for taking on the responsibility.
Well, let's move to questions from our tribal citizens.
You bet.
And so the first question comes from Courtney. And as we go through the questions, and as I was looking at them, some of them have been touched on in your presentation, but it might be good to re-answer those and focus maybe a little bit more on each one of them. The first one is, will there be one shot available instead of two?
Yeah, we do have some of the Johnson & Johnson vaccine available in both Juneau and Sitka. Not large amounts, but I know it's been a source of happiness and solace for people who have wanted specifically to receive that vaccine, and we have been giving it in our clinics to those folks for whom that makes a difference. And it is, I think, having a single shot is obviously it sounds better than having two, right? But it also the reaction to the single shot is maybe a little more robust, certainly, than the reaction to the first of the Pfizer and Moderna. That's not been quantified scientifically, but that's just anecdotal.
Well, and then with the information that you've provided today also lets us know, and we're making informed decisions about whether we want the one shot Johnson & Johnson, or do we want to see a two shot, which will give us better coverage.
Yep.
With the Pfizer or Moderna vaccine.
Yeah, good point, Roald. And yeah, there is a difference in the overall effectiveness.
So Rachel's asking, my granddaughter has had her first vaccine and she had headaches and had been very tired. She's hesitant to get a second one. So the Indian Health Service in Portland isn't prioritizing people who just moved there and received the first vaccine in another state. Shouldn't they follow through with the second dose for her? Absolutely. She will have to get a third one otherwise.
Absolutely, they should. And you should not mix. I mean, it's not recommended that you mix, if you got the Pfizer, you should finish the Pfizer or what have you. I realize that in some other locations where vaccines are not as available, that's going on, and that people are moving down in their priority because of the scarcity of vaccine. On the other hand, right now in the United States, we are giving between 2 and 3 million injections a day in this country. That represents a phenomenal amount of vaccine being pushed out into all 50 states. So my hope and prayer is that your granddaughter will be able to complete the series there in a timely way. If not, and if she travels back to us, we will take care of her.
Thank you, Dr. Bruhl. The next question up is from Harry, and he'd like to know if there's a danger of getting the virus even after vaccinated.
Yes, Harry, there is some danger. It's greatly reduced. And as I said, the likelihood of having a serious infection if you got vaccinated with Moderna or Pfizer is reduced by 95%. So that is really, a wonderful amount of protection. Now, is there a chance that you could have an asymptomatic infection? That was kind of what I was talking about with regards to the whole idea of the breakthrough. So the breakthrough, the thing that's getting broken through, is the protection of the vaccine. So what is the likelihood of that? Well, it depends on where you go and who you're exposed to and whether or not you're using personal protective equipment like a face mask and washing your hands and avoiding sticking your finger in your eye and all of these other things that are hard to do. I can't believe how much I touch my nose, so, you have my sympathy on that challenge. But the data show that the likelihood once we've been vaccinated, and this is like as a population, so it's not maybe for each of us individually, it could be different, but overall in the population, once we've been vaccinated, the likelihood of it having an asymptomatic infection where you're not getting sick, but you still are positive, it's dropped by 66 to 80%, which is a lot. Still not perfect.
But great numbers. The next question is from Henry, and he said, I've heard some people say the survival rate from infection is 97%. Protection from the vaccine is only 94 to 95%. So a question might be, why bother with the vaccine?
Yeah, well, those statistics are really not statistics on the same thing. So there's a number of reasons why getting vaccinated is important. So, and of course, the first one is personal. It has to do with protecting yourself and protecting yourself from serious consequences of this disease. And there's nuisance, quote unquote, consequences, like I talked about my daughter who can't smell. I'll tell you what, after 3 or 4 months of not being able to smell your food and having everything just taste like mush, that is a pretty significant thing, but not nearly as significant as ending up on a ventilator or dying. And elderly people are not the only people who die from this. Young people die from it. Young people have strokes from this virus. Young people have serious respiratory lung issues that last. We don't know how long they'll last, but they seem to be lingering. So this is a very, very wicked disease. Now, it's true that some young people will get it and will experience nothing more than the symptoms of a cold. But there's another reason that doesn't have to do with you personally, and that has to do with the fact that we're members of a community, and the safety of our community depends upon all of us, or to a very large extent, as many as possible, getting vaccinated. That is what will prevent this virus from continuing to circulate. So why do we want that? Well, we want that because we want our economy to be open. We want our tourism and our fisheries and our businesses and our schools to be able to open. So that's an important, as members of the society, it's important for us to do that. So if I'm a young person and I'm maybe not at high personal risk, I'm still a member of society and I still depend on that. And so it's part of our personal responsibility to our communities. And lastly, if this virus is allowed to continue to circulate, the likelihood that other variants will emerge that are much more difficult to treat will emerge with time. So really what we want to do, and when I say we, I mean Dr. Zink, Dr. Fauci, myself, all of us who are in leadership roles in medicine, what we want to see, and we've been saying this, we want to see this shut down. And it can be shut down if we are really good about vaccinating in this country and vaccinating in our communities. We can shut this down and it can go away. It's a real potential. If we dilly-dally and we don't manage to really get good vaccination coverage and this continues to smolder, the likelihood of something truly bad emerging goes up.
I appreciate how you've commented not just on the personal responsibility, but also the community responsibility here, and cutting COVID off from being able to mutate and have additional variants that will be even much worse or not susceptible to the vaccination. So I appreciate hearing that answer, reminding us it's not just always a personal choice. As community-minded people, it's also a community choice.
It's what's really at stake. So yeah, absolutely. And that's not a theoretical thing. I mean, we know scientifically that that will happen if this continues to circulate, that, you know, it will continue to change. And, you know, we don't need another flu, you know, something that we're constantly battling.
The next question is from Rachel. It says, even if we get vaccinated, can't you still spread coronavirus if you were around somebody who has it?
Well, yeah, this kind of comes back to what we were just talking about in terms of the likelihood of having a breakthrough infection. In order to spread it, you would have to contract it. And what we know is if you've been vaccinated, that there still is a chance of contracting it, but it's much, much reduced. So the answer to your question is yes, but that the likelihood of that happening is reduced dramatically. And if we do that for all of us, then that will prevent this virus from circulating in our communities, and it will go away. It'll die out.
In one of the earlier answers, you answered the first half of Courtney's questions about having shots available for in Juneau. But can you talk about, will it be available to everyone over 16?
Well,
and maybe I could be specific. She had mentioned the one shot, so I think she's talking about Johnson & Johnson.
Yeah. I apologize that I don't recall if Johnson & Johnson is authorized for 16 to 18-year-olds. I believe it's only authorized for 18 and above is what I'm recalling, but there's so much information. But right now, I believe that Pfizer is the only vaccine has been validated for people 16 and up, and that the Moderna and Johnson & Johnson is 18 and up. And we do not have a large supply of Johnson & Johnson at this time, but we do have some, and we have been giving it. We have a really robust supply of Pfizer and Moderna, and we have been working to extend those vaccinations into the broader Southeast Alaska community, because really the health of our overall region is so important to the health of each one of us. Going back to my earlier comments about communities. So what does that mean? That means that we have been donating thousands of doses to the city and borough of Juneau, and the city and borough of Juneau is going to be standing up some very large vaccination events for all members of the Juneau community. And when we protect all members of the Juneau community, we protect all members of our tribal citizens, and the whole community becomes safer, because this is really a community-based problem, and we can't really address it unless we begin that kind of outreach. So I showed you the numbers earlier, and we have managed to vaccinate the vast majority of our tribal citizens, and certainly almost everybody in our tribal groups who have wanted a vaccine have had an opportunity, and will continue to have that opportunity. But we're trying to reach out now into some of the broader community. So we've been donating vaccine to Petersburg and to Skagway and to Juneau and to Ketchikan, and really trying to and not insignificant amounts, thousands of doses of vaccine into those communities, in an effort to raise the overall safety of Southeast Alaska. We've also been participating in efforts to vaccinate people in the fisheries industry that are starting to come into the region. Why? Because it makes us safe. It makes our children safe. So, and it supports our economy that we all depend on. So I hope
I
that
appreciate hearing about the donated vaccine to our other communities across our region, and appreciate SEARHC's effort. I'd heard about the donation to Ketchikan. It's great to hear about the donation to Petersburg and
Yeah,
others.
absolutely. Yeah, and of course we have a lot of beneficiaries in all those communities, as well as um, a lot of other folks that we work with.
So Marvin has asked, and I think this has been much in the news lately, how much truth to getting blood clots from the vaccines?
Oh, Marvin, good question. Let's talk about what's happened in Europe. I'll try to be succinct. Um, there, it's true that there are people who've experienced blood clots, and it's true that there are people who've been vaccinated. It does not necessarily mean that those two things are related. That would be the most significant, sort of succinct way I could put it. So when this was studied during the phase 3 trials, um, there are people who are receiving vaccine who are experiencing all of the potential health outcomes that anybody can experience, unfortunately. So if you vaccinate 1 million people on a Monday, I guarantee you there's going to be people in that group that receive that vaccine on that day who are going to have heart attacks, strokes, clots. All of those things will happen at that same time. That doesn't mean that the two necessarily are related. So what happens when they do phase 3 trials is they look at this exact issue to see if they're in the vaccinated group of people, if more of these things are happening than in the baseline unvaccinated group. There's very, very complex statistical, mathematical ways of examining that. And with regards to the incidence of blood clot in people that have been receiving the AstraZeneca vaccine, which is not an approved vaccine in the United States at this time, the scientific answer is no. There's no higher incidence of those unfortunate events occurring in people who've received the vaccine than there is in people who haven't. So how did this occur? This occurs when there's a mixture of politics and science. And what happened, unfortunately, was that there were some young people who experienced clots. And I'm telling you, I mean, in the course of my career, this is just something that does happen. Unfortunately, people have pulmonary emboli and strokes they're much more common in older people, but they do happen in young people. And there were a couple of these things that happened for some young people in Norway, and the politicians said, oh, this has got to be related to the vaccine. And then there was kind of a cascade of fear that occurred amongst politicians. And eventually, over the course of a week, cooler heads prevailed, and people looked at the science behind this and said, well, no, this is not occurring at a higher rate. And so most of those countries have reinstituted their vaccination efforts using the AstraZeneca vaccine. But unfortunately, that fear has greatly undermined their efforts and ability to do that. Now, with regards to the vaccines that are approved here in the US, the answer is no. They don't. There's no evidence that they cause blood clots. There is, however, good evidence that COVID-19 does cause blood clots and does cause strokes. As a matter of fact, there's very strong evidence for that, all of which argues for all of us to get vaccinated.
That's an excellent point, and I appreciate that you answered that tough question, especially since it's so much in the media as we speak. Henry's asking a question. He says, my Rotary Club and I suppose, and he supposes many similar clubs and organizations are already talking about how to transition back to meeting in person. One question that has been posed in our group is if we should limit in-person attendance at our meetings only to those who are fully vaccinated. Is that a good idea? Does it matter? If most people are vaccinated, does it matter if people who are not vaccinated attend? And do they pose a risk? Do they pose anyone a risk? So a lot of questions built in there, but it's really one of the questions of the day for those who've been vaccinated.
It is. And Henry, it's a great question. Like all of these questions have been excellent. And this is another good one. Well, the strict CDC guidance at the present time says that we should allow ourselves to get together in small social groups and family groups where people have been fully vaccinated. They have not yet moved forward with recommendations regarding organizations like your group or like a church group or others. They continue to recommend that people use face masks and social distancing in those settings. So that would be the official answer. Nevertheless, will that be coming around the corner here in the near future for what you're talking about? Absolutely, it will. When? I don't know. Hopefully soon. In the meantime, do I think that that's medically appropriate? Absolutely, I do. I do think it is. And I'm sorry that some people find this in some way to have some sort of civil liberty implications, but really looking at this purely from a safety and medical epidemiology point of view, these things, this is definitely going to be a part of our very near future. So I see, in all likelihood, I see, airlines, cruise ships, other types of organizations insisting on that. And I don't think it's unreasonable. So best answer I can give you right now, Henry. Great question.
It was a great question. Thank you, Henry, for that question. Christina has a question. She says, have they started a study in children yet? My daughter
Absolutely. Yeah. Yeah, it's going on. It's not in infants and babies and toddlers. I think the bottom half of the study group is about 5 or 6 year olds, but they are studying it, and my expectation is that we're going to see results and recommendations by the fall. Yeah, so it's going on.
Excellent. Thank you for that. Helen asks a question. She says, my husband and I believe last year in January that they had it for about nearly 2 months long. They lost so much weight. One was down to 101 pounds, one was down to 120 pounds. Is there a test to find out if they had it before? And if we did, they'd like to know if they did have it, and if they did, do they still need a vaccine?
Great questions. I'm sorry that happened to you. Yes, there is a test, and it's a blood test that will look to see if you have antibodies in your serum from having had the COVID-19 in the past. And I can understand that you might have an interest in knowing that. But really, regardless of whether that's true or false, you should get the vaccine. So why? Why should somebody who's already had COVID-19 get vaccinated? You should for several reasons. One of the things that's interesting is the vaccine actually seems to prompt a immune response that is more protective than actually having had it. I know that seems crazy, but it's true. That's what the data show. The other thing that we seem to be learning about the virus is the variations in people's experience of illness when they contract COVID-19 may have less to do with the virus and more to do with our immune system. So the difference between, say, me and you, if maybe I'm getting really sick and you're not getting very sick, may have to do with differences in how our immune systems handle the virus. It turns out that the vaccine for many folks where it's been studied, and this is kind of a difficult thing to study, but it's been studied, and it turns out that the vaccine appears to promote an immunity that's stronger and more durable. So my recommendation to you and to your husband is that you do get vaccinated. And for those of you who've experienced a positive COVID-19 and are wondering the same thing, the answer of when to do it is the point in time when you've completely recovered from the illness.
That's very helpful to know, as many of us in our families, we've had COVID-19.
Yeah.
And so I appreciate hearing that. Henry has a question and a bit of a criticism. And this isn't just about COVID, it's about other epidemics that our world has experienced. And so he says, why wasn't the world able to make a vaccine during the global HIV/AIDS epidemic, but we could do it with this virus?
That was a great question. Well, a huge part of the problem in the world's response initially to HIV and AIDS had to do with the fact that the people who were getting sick were people in the homosexual community who we all know have been victims of extreme prejudice and really that there were attitudes of accepting that this could happen to those people. So I know that's not directly what you were asking, but I mean, that is the truth. I was in my training at that time when the AIDS epidemic really first started. I was in my training. I was working in a large inner city hospital in Denver. And I can tell you that, virtually every night when I was on call, there were young men that were dying in that hospital. And it was, I still feel traumatized by what I experienced there as a young doctor. So there were, as like with most of these kinds of things, there were also some good things that came out of that. A vaccine has not come out of that. There's scientific reasons for that. So thankfully, the structure of this virus is such that it can be combated with a vaccine. Now, the problem with the AIDS virus from a scientific and medical point of view is that the AIDS virus actually targets cells in the immune system. There's not a lot of viruses or illnesses that do that, but it actually the virus infects and kills the very cells that we use to fight disease. So the CD4 cells that the T helper cells that are important in our immune system, and for that reason, it is particularly pernicious. It has some other features about it in the way that it disguises itself once someone's infected with it. So all of those things have made it technically difficult, if not impossible, to vaccinate people for HIV. So that is not a consequence of lack of effort, actually. There's been tremendous effort in that. But the lack of really response of the worldwide medical system to that disease in its early years is, it's one more shameful chapter in the bias that exists in the established medical community and in society. Medicine's no different than the society within which it lives, and it's a sad reality. I count myself amongst people in medicine that are working actively to combat those forces. But this is a struggle that's going to take unacceptably long amounts of time to change. It's a really sensitive and thoughtful question.
And
I hope that I've answered some of it.
I think that you have. I hope Henry appreciates your response on that question and that criticism as we look at the difficult efforts around combating disease and past epidemics, and what lessons we've learned there about how our society should respond. And I think that there's equivalence between what society's response is then and how we apply it today, in saying, are not our personal liberties more important than pandemic response? And so, well, aren't exactly the same in the dialogue and the conversation, as we put it in the view of the public and the community, it becomes important.
Yeah, and so there's elements of the same issue in our response to communities that are not fully valued and respected in our culture, and Native communities are one of those communities. In many areas of the country, people are completely unaware of even the existence of the Native community, much less respecting and valuing it and its contributions to society, as well as its history. So what we've seen the data show is that people who live in these communities have experienced a disproportionate effect of the disease. So the Black community, the Latinx communities, and Native communities. Some of the areas that have had the very, very highest levels of morbidity and mortality include the Four Corners area and the Native communities there, as well as Western Alaska, and some of the smaller communities up in the Yukon Delta. And so those, I think, so here, Roald, if I can just speak to one thing. I think there's a popular perception that's unfortunate that says, oh, well, people in those communities are just more susceptible genetically. And that's not true. There is no data that support that. It's the fact that people in those communities have other social determinants that result in the disease having a more profound effect. So what are those kinds of things? Those include living in multi-generational households. Those include not having access to care, not having the economic ability to access care, and don't forget, lack of trust of care. So if if you're not able to trust the people that provide care to you, then you're going to delay seeking care for a longer period of time. Now, these are challenges that we here in Southeast and in our organization, we are aware of these things, and we are working actively to break down those barriers and to build trust with our communities. But we have challenges with that, and those challenges include the fact that a lot of our clinicians and nurses, of course, are from the dominant culture. And so helping them to understand the challenges of our Native communities is part of the work that we do and have to do, as well as continuing to work to support the development of more health professionals from within the Native communities and working actively to recruit and find qualified Native medical providers, and we're doing those things.
Excellent. I know we're running very short on time. Maybe I can put two of these questions together as they're from the same person, and then we will get answers to Rachel, and we will get answers to Charlene as well through our communications crew. But one question is, can you speak about the efficacy claims of the Johnson & Johnson vaccine increasing from 70 to 90% over time? And there's a follow-up question about that is, can you explain the difference between efficacy and effectiveness?
I not sure that they're, while they're semantically are different, they're generally used interchangeably. So I guess I'll leave my response to that. And with regards to Johnson & Johnson's claims of differences differences between 70 and 90%, I believe that they're referring to post-marketing data. So what they're doing, of course, with all of these vaccines, we continue to collect data for people who have been vaccinated. And so I believe that the folks at Johnson & Johnson feel that in post-marketing data that their vaccine will be more effective than it is. For the time being, we conclude that the 70% number reflects good data from the phase 3 trials. And from my perspective, it's really not important, because really, in terms of actually stopping the pandemic, whether it's 70% or 80% or 90%, it's very, very effective. And what we know from other vaccines that are maybe only 30% effective is that for a virus that's as transmissible as this one is, that it should be good.
Háw'aa, Dr. Bruhl, thank you for spending all your time. This has been incredibly informative. I hope that our citizens and other guests who have joined us on Facebook today also find this just fascinating. The update, the real life information is great. So I appreciate our partners in health, SEARHC, and you, Dr. Bruhl. Hopefully when this pandemic is over, you and I can grab a cup of coffee. I look forward to that.
I do too.
And to close out our chat session, we want to thank everyone for tuning in, and we will have a random drawing for those of you who have liked us on Facebook. And so the winners are, the door prize winners, Hydro Flask goes to Gail Young and Dabalas, and David Boxley Formline t-shirt goes to Keith Sims. So those are our winners today of the random drawing. Please join us again for our next lunchtime chat. Again, Háw'aa to you, Dr. Bruhl, for joining us and sharing all this information, asking all these great questions from our citizens joining us today. Gunalchéesh, Háw'aa for joining us.
Gunalchéesh.
Don't forget to join us next Thursday, April 1st. It's not a trick, where we'll be here to learn about our Village Public Safety Officer program. Háw'aa, how strong sing song. We'll see you all again.